To learn more about efforts to treat the whole person by integrating medical and behavioral health services, we're now joined by Suzanne Kunis, Director of Behavioral Health Solutions at Horizon Blue Cross Blue Shield of New Jersey. Horizon Blue Cross Blue Shield of New Jersey is investing in innovative partnerships to bridge gaps in access to behavioral health care and accelerating efforts to integrate medical and behavioral services, which is improving care coordination among providers and ultimately improving patient outcomes. Suzanne is leading Horizon's efforts, including developing new behavioral health programs and services, and she joins us today to share this important work. Suzanne?
Thanks, Catherine. And following Paul's lead, I do have a lot to cover, and I want to be respectful of everyone's time, so you're going to get the Jersey speak here to try to help to move this along. So let me just going to slide 2. It's just really a little bit about the organization. We are the largest and oldest health insurer in New Jersey. We cover over 3.5 million members, which represents about 50% of the insured market, or over 50% of the insured market. And the fact is, we feel as an organization very strongly positioned and really an accountability to help to make an impact here. And it's a huge opportunity for us with the coverage that we have in New Jersey. So I'm not going to go into a lot of this. Paul covered most of this, but I think that everybody needs to understand, and one of the messages that we continuously try to get out there is mental health problems are very common, but despite that, stigma stands in the way of people being willing to get treatment. We looked at some of the Mental Health America statistics, et cetera, and when you look at chronic illness, recognizing that about 59% of people have a comorbid physical health and behavioral health issue, when you start to look at the costs that are associated with it, we're talking triple the utilization of healthcare resources for the individuals who are struggling with both mental health and physical health issues. So New Jersey is not unlike the rest of the country from my past experience, but what I can tell you is just focusing on our state, aside from stigma being one of the greatest challenges that we're facing, we have a significantly fragmented care delivery system, and in 2 ways. Limited coordination between physical health and behavioral health providers, and on the behavioral health side alone, there are significant gaps in services being provided. An example, if someone has a substance use disorder, they're heading off to a rehab. As they're being discharged from rehab, they're being given instructions to attend an IOP program in the next day. The person does not show up the next day and no one goes looking for them. So we're trying to address both the integration of physical and behavioral health, but also trying to address the issues within behavioral health itself. When you go to a primary care physician's office, you probably have a 7-minute office visit, which is the average, and in 7 minutes it's not easy to try to, or it's not even probably possible to address behavioral health issues on top of physical health issues. And aside from medical school rotations, most PCPs have not had any formal training around behavioral health and the effect of, the issues associated with comorbid conditions. We also are looking at patients from a holistic perspective. So we want providers to treat patients as people, not conditions. Thirdly, looking at access issues, we have, we know that about 60% of treating psychiatrists are over the age of 65. So as you can easily see what that's going to look like in the coming years. And child and adolescent providers, psychiatrists, we're talking 15 million kids needing service, and about 8,300 child and adolescent psychiatrists are out in the world. Some of them tied up with research and academics, et cetera, not necessarily treatment. We are in New Jersey are focusing attention with our provider partners on increasing psych residencies and actually doing a lot of training within the medical schools around the integration of physical health and behavioral health. But we need more alternatives to the traditional treatment providers, psychiatrists, social workers, psychologists. As Paul had indicated, there are not enough behavioral health clinicians out there to be able to address the need. So we're really spending a lot of time and energy around looking at different systems of care as well as different types of interventions that can occur at the primary care level. We have an out-of-network challenge, and I'm sure, again, many of the other insurers around the country are dealing with this, where We have lots of people leaving the state, heading to Florida, California, and Texas for treatment. And we have a long way to go to change things up, and part of our responsibility is how do we make care available here in the home community to really take any reason for people leaving the state off the table. The opioid epidemic, there's the lack of evidence-based treatment and substance use. We're real excited on the MAT front for opioids, but there's still a lot of work that needs to be done in this the model of care, if you will. But in New Jersey, specifically as it relates to opioids, more than on average, 8 people die every single day from an overdose. So not a good place to be. And again, making lots of effort to turn the tide, but still a tremendous amount of work to be done. Moving to the next slide. So as we were trying to develop our strategy about how we're trying to approach what we're doing here in New Jersey, we stepped back to say, what do we need to think about to ensure that the system of care that we have in place meets the needs of our citizens here in New Jersey? So the foundational elements are laid out here. A couple I wanted to mention quickly are treatment in the home community is clearly an important thing because going away and coming back, the issues are still the same. So we want to make sure that we have the supports here in the state of New Jersey. Patient navigation, we need to stop patients being lost between physical and behavioral health and between the various treatment modalities within behavioral health. And as Paul talked about, these are our most vulnerable members, so we really need to step up and go way above and beyond what has been done historically. Community-based services, we're very interested and have nice relationships with some of the CCBHCs here in New Jersey. It's these certified community behavioral health centers that were SAMHSA granted a couple of years ago. The scope of services that they're providing is incredibly positive, and the more we work for keeping people in the community and expand those types of programs and community-based services, the better our members will be. We're also looking at how do we remove obstacles to treatment. So aside from the fact that we have to deal with the whole treatment and recovery program for all of mental health and substance use, we want to make sure we're removing all the obstacles, homelessness, joblessness, as much as we possibly can in order to help people to get the services that they need and to live a healthy life. We are a commercial insurer as well as we have government programs business, but on our commercial side, we typically have not paid for services around housing supports, peer recovery, but we're totally shifting the dynamic here and trying to get into a new world on the commercial insurance side and trying to take some really positive lessons out of the community health world. So going to the next slide, as we developed our strategy, we wanted to make certain that we had solutions in place for everyone with needs across the continuum. Most of our efforts have been focused on quadrants 3 and 4, which are the high-end behavioral health, low-end physical health, and high-end behavioral and physical health, primarily serious mental illness. Again, what you'll see in a moment is we have solutions across the continuum, but really our greatest effort is looking at those individuals who are in quadrants 3 and 4. So with that as the backdrop, and with the focus on members in quadrants basically 2 to 4, let's talk a little bit about our integrated approach. So as I mentioned, we have solutions across the continuum, everything from health and wellness to SMI. And I wanted to give you a sampling of some of the work that we're doing. So this isn't all-inclusive, but it's an idea of some of the things that we're actually working on and have implemented or are on the way of, in the path of launching. So as you can see, the continuum of services here, basically the intensity of resources and the level of engagement increases dramatically as you move along the continuum. And if you, again, we're highlighting here, according to the quadrants, the types of programs and services that we have implemented or will be implementing to support members in each stage of their illness or health and well-being. So we have, we've implemented a variety of pilots around integrating physical health and behavioral health. So we are supporters of the collaborative care model, and we reimburse for those services. We are working with provider organizations who have embedded clinicians in their primary care practices. We have hybrid models, the Cherokee model, as many of you are knowledgeable of. And then we've just recently being 2018, launched a program with Quartet Health. So we reimburse for collaborative care. We also reimburse for behavioral health screenings in a primary care setting, but we have a huge opportunity to do so much more in the way of education and training of the network, and we will be doing that in the coming months and years. I wanted to spend more time talking specifically around our Quartet relationship and our Able To relationship. So I will do that in one moment, but before I leave this slide, I wanted to mention that we're also trying to look at episodes of care and other value-based financial arrangements with provider organizations. Behavioral health, and again, we're not unique here, but it's primarily been a fee-for-service world in the commercial side of the world, and we are trying to move that more from fee-for-service to fee-for-value. We've implemented 2 episodes over the course of the last year, one in substance use disorder, and the second for inflammatory bowel disease, and really making behavioral health and physical health a single view for providers to help patients to be able to address the issues that they're facing as part of their disease. Okay, so Quartet Health, it's essentially virtual integration at a primary care level. The value prop here, Quartet leverages proprietary algorithms that they use. They take claim data from Horizon, run them through their algorithms, and essentially identify members with an undiagnosed or a latent behavioral health problem. This is a primary care physician-focused initiative, and what they'll do is, as a result of having done the claim analytics, they'll identify people who could benefit by having a behavioral health intervention. At the same time, there is also the opportunity for primary care physicians to surface patients to Quartet. And the reason we're doing this is, and we're making it available for any person that's being treated in a primary care setting, regardless of whether or not they're a Horizon member. We know that there are enough challenges in a primary care setting and enough priorities, and timing is not on our side, that we're trying to make certain that it's easy for primary care physicians to be able to say, I've got a patient, regardless of insurance, no insurance, what type of insurance, that they can actually surface to Quartet, and Quartet will connect them to behavioral health practices. And there is an app that is used, so we engaged. Actually, we have over 1,200 primary care physicians in our first pilot and over 550 behavioral health practices in the pilot. And there is an app that's used between both practices, and so patients can be referred into behavioral health treatment from there, and then the behavioral health practices are able to communicate back to primary care that, yes, I have your patient. Yes, we have a treatment plan. Yes, there are medications that are involved. And it really changes the dynamic. I know for many, many years, primary care providers were afraid to do screenings because they didn't know what to do if the patient screened positive and how they would respond to that. Now we've got this tool in place where we are actually giving them the opportunity to surface patients, get them into treatment, and know on an ongoing basis what's actually going on with those patients. There is an expedited referral and coordination process between the behavioral health and primary care physician. And we started this off in January of 18. So the first year was really a build year. And as I mentioned, we've got over 1,200 primary care practices that are involved. And during that first year, Quartet has surfaced over 2,500 members to primary care as people who potentially could use a behavioral health intervention. And then 1,700 of our members were referred by the primary care provider into Quartet to get that patient set up with treatment. And then there were several thousand others that had no relationship to Horizon that actually were referred into behavioral health treatment because of the way we set this program up. It's a program that is currently focused on adults. We were, again, limiting it to a certain, we have 15 priority health systems that we have engaged primary care practices through. We are not at the point yet where we're able to see a demonstrable ROI because it was really the first year was primarily a build year. But we expect that we'll be able to analyze that by the end of the first year, by the end of this year. Having said that, we have seen such positive feedback from the provider community like we've never seen before. Most providers are not out proclaiming the value of a health plan, but there has been such great response to this, and we have lots of testimonials from providers that are actually utilizing the system that we've decided to scale this statewide, and we will be doing so in the coming months, even while we wait for the demonstrated ROI. The program is currently focused on adults, but our next phase is actually going to be working on the child and adolescent population. We're fortunate in New Jersey to have access to the Pediatric Psychiatry Collaborative, which helps with getting patients, kids, it's funded by the New Jersey Department of Children and Families, and there's a way to get kids into treatment, but we want to take that to a much greater scope, if you will, over the course of the next year or two. So as much as Quartet was a PCP-focused program and a focused integration effort, we also have a relationship with Able To, and that is a member-focused program. So it's virtual therapy and coaching for people with depression, anxiety, and stress, and you'll see a little bit more of some of the programs that are available. But it's a telehealth solution, again, using claim analytics to identify individuals with chronic medical issues that could benefit by a behavioral health intervention. So it's an 8-week program, includes CBT and coaching via secure phone or video. They will have one coaching session a week by an individual who is a master's level clinician, and they will have a therapy session by a licensed clinical practitioner a second day during the week. So it's 2 visits a week. It's an 8-week program, and there is follow-up support services that are available to the members. But the focus of it is to really see how we can intervene and help people to deal with the issues that they're dealing with their medical issues, with their medical problems. The outcomes focus that we're looking at, we're measuring this by what is the impact on overall total medical expense, and secondly, and actually more importantly, the outcomes focus around what's happening with the scores that the individuals are completing over the course of that 8-week program. So the DAS scores, Depression, Anxiety, and Stress Scale, is utilized, and we monitor that over the course of the program and into the future. We are continuing to expand the program. Again, people that go through the program and graduate have greater than 97% satisfaction with the program. And so we think we're trying to do the right things by having a PCP-focused intervention, a member-focused intervention, and then lots of other things that fall around both of those. The next slide just briefly shows you the extent of the programs that are available under our Able To model, but it's really dealing with all kinds of issues that you would deal with in life, including traumatic life events, your medical condition, and then just basic psychological distress. Okay, so I mentioned earlier we have a focus on substance use disorders and the opioid crisis. It's a huge area of focus, and we've made a significant investment as an organization in really making certain that we are stepping up and doing all the right things. We're focusing our program around education and prevention, treatment and recovery, community engagement. We're piloting a lot of different solutions, and the reason is this is such a huge challenge in the state that we really need to just throw everything at it to see what possibly can be done to help individuals to get into recovery and to stay in recovery. Our pharmacy program is quite robust. Our lock-in has been quite successful. As you see some of the highlights here, we have prescriber-focused risk identification programs. We have a prescriber toolkit to help with educating providers around best practices. We're working with the DEA and the Partnership for a Drug-Free New Jersey and so many other community organizations to really hone in on what's happening, what are we doing as key stakeholders in the state, and coming from all walks of life to be able to try to get this crisis under control. And then we're really emphasizing best practices, MAT, medication-assisted treatment, and helping to actually establish services in areas of the state that where it doesn't exist. So as you can see, as I just mentioned, increasing access to medication-assisted treatment services. We will have a teletherapy solution set up shortly that will be specifically focused on substance use disorders. We've actually partnered with an organization called MAP Health Management. We're doing a pilot program, and it's a technology-enabled peer support where at the point of discharge from a higher level of care, inpatient or residential type of program, as well as at the point of entry into outpatient treatment programs, the individuals will have the opportunity to engage with a peer who is in recovery, and they're certified peers, and they provide a structured outreach program 4-time contacts during the early months, and there will be an outreach from the person in recovery who is actually the peer to the individual who's struggling with getting in and staying in recovery, and then that patient as well as their families will have 24/7 access to the peer. We thought it was very important that we made sure that the families or support system were able to get into the peer whenever they would see one of their loved ones actually beginning to go down a slippery slope and actually help to bring them back and re-engage in treatment. So lots going on there. Peer support, and again, I know, Paul, you had mentioned about it. We are huge supporters of peer services, not just for substance use, but also for mental health. And again, typically not a service that has been covered under commercial insurance, but we're trying to change things up to really include a whole new scope of services that will do the right things to get people the care that they need and then into recovery and stay in recovery. And in the end, you do the right things and the money will follow. And then lastly, I wanted to spend time on this program that we are going to be launching this summer, and we're really excited about it because we think it's very different than what's actually been sitting out there and addressing all the challenges that we've been facing. So it's called our Integrated System of Care, real creative title, but it's targeting the most vulnerable members that we have, which are the most complex member needs. So the core of the program is our behavioral health integrator, and it's really a center of care. The first one that we're working with is an organization that is one of the CCBHCs here in New Jersey. And what their role is they're going to continue to provide the full scope of services they do presently for members who actually approach there for treatment, but they're also going to be doing a higher level of service in terms of patient navigation. That's really what we're trying to focus on here. Our objectives are to reduce the delivery system fragmentation, increase access by improved navigation of members. We don't want people to keep getting lost in the system and fall through the cracks, and improve the quality and reduce total cost of health care. So for the last 12 to 18 months, we have focused on developing this model. We've identified the integrator and the roles and responsibility for the integrator, which, again, it's on all aspects of this. So our model of care, the ecosystem, includes not just behavioral health issues, but it's really bringing into play the physical health pieces and delivery system, as well as addressing the social determinants that we need to address to ensure that people are able to engage in treatment and to stay in treatment. So we've identified our integrator for our pilot. Again, it's in one small area. And we've also identified a health system partner, one of the major health systems here in the state. And they currently work together on a very small basis, but what we're doing is formalizing this approach and really making certain that we have all of the tools in place that we need to, including feet on the street, et cetera, to be able to get people into treatment, regardless of what their treatment issues are, make sure that they attend treatment services, make sure that we're tracking outcomes, making sure that they're fully engaged as well as their family, and doing whatever we need to do to try to change the trajectory of illness for people that are in the state and in this pilot program. We did seek expert input. We've approached a couple of nationally recognized individuals and organizations for their input and had received great feedback and support for the program that we're launching, and we're expecting to be live this summer. So it's pretty exciting because if things go as well as we're hoping that they will, then we are hoping ultimately to scale this statewide. But we're going to start in one small corner of the world and go from there. To give you a sense of what we believe can happen, so we have as I mentioned, a behavioral health practice that we've identified, and we have a health system that we're working with. Today, there are 77 people who are actually being seen in both systems for physical health and behavioral health. Prior to actually even implementing some of these changes, we knew that we were partnering with the right people because as you look at the average total PMPM, those individuals who had not visited this practice and potentially not had behavioral health services at all, their total PMPM is 15% lower than those who did not visit that practice. When you look, and then we split it into the physical health PMPM and the behavioral health PMPM. So as we mentioned earlier, costs are generally 3 times higher for individuals that have a comorbid condition. And here we're looking at, again, in the early sample of work that's already being done on a limited basis, we're seeing a 35% lower PMPM on the physical health side of the equation. So, again, small numbers, we understand that, but we think it definitely reflects evidence of that strengthened integration between physical health and behavioral health really will improve overall outcomes and reduce overall cost of care. So our next steps here are that we are going to be launching and we'll be monitoring over the course of the next 6 to 12 months and waiting to see what the results are. It's been a journey getting to this point, but we're really excited about the potential. And with that, I'm going to end my presentation, and thank you for your time.